Hi, I'm Michael Reinhardt. I'm a geriatric psychiatrist and director of the Brooklyn Initiative to Develop Geriatrics Education. It's my pleasure to be here with you to talk about an important topic, normal aging and development. This topic is very important for all learners across all health professions to help you understand what is normal and what is abnormal. Understanding what is normal helps to limit unnecessary care for older adults as we age. And understanding what is abnormal, of course, helps to target what is appropriate care intervention and diagnostic testing. I have no conflicts of interest to report or to discuss, and I will not be talking about off-label treatment today, but will be talking about some treatments that are under investigation for aging and may become available in the future. Our learning objectives today are listed on this slide. We'd like you to develop and enhance your ability to define normal physical and physiologic changes of aging, to be able to define the normal developmental stages in older adults, to describe the difference between normal and pathologic aging and how normal aging and pathology interact, and to name at least 3 pathways to healthy aging, including lifestyle and preventive health care. Before we get too far into this talk, I'd like you to take a moment and just to think to yourself, as you complete this module, how old is old? What do you consider old to be? And to bring some focus to this idea, the AARP has an Disrupt Aging campaign. And I'd like for you all to take a moment to watch this video and has you help to shape your thinking about what is old and what is aging.
Hey, how's it going? You can stand right there, that's your mark. How you doing?
I'm great, how are you?
Great.
Awesome.
Just tell us your first name and your age.
My real age?
My name is Paolo. I'm 25 years old.
My name is Daniela, and I'm 19.
24.
35.
31. 33.
I'm 26 years old.
What age do you consider to be old?
Late 40s?
Maybe 50.
I feel like 30 is a new 20, so I'd say like 40 is old.
I'd probably say 50s.
I'd like you to show me how an old person would cross the street. Show me how an old person would send a text message. How might an old person do a push-up? What about jumping jacks? Okay, hang on. There's someone I want you to meet.
Hello, I'm Birch. I'm 66.
Hi, I'm Daphne, and I'm 68.
I'm Dee, and I'm 55.
George Fassbinder, 75.
My name's Parvati. I'm 70.
Nice to meet you.
Nice to meet you.
We're gonna give you about 2 minutes to teach each other something that you are good at.
I can teach you a jump that I do.
Okay, please.
Both of your legs go up, and your arm goes up, and your left arm goes like to the side. Ready?
Okay.
1, 2, 3. Lift 1, 2, 3. And bring it to your heart. And bring it to your heart. Add the head in. Yeah.
You want to try to get your balance and raise up. Now, you can bring your legs and your feet up. It's hard, right?
Yeah.
1, 2, 3, 5, 6, 7. So when you come out of a turn, either way, you go back to that basics.
Over. Now forward. Over. Yeah.
Square it like this, and give me a hook. Hook. Jab, cross, hook, and then we'll go like this, all right?
1, 2, 3.
Now, what age might you consider to be old?
Probably 80 or 90. He could just do everything that I told him to do.
An age that I would consider to be old now might be 100.
Do you remember what you said?
Yeah, I said in the 50s. I thought that would be old. But when I thought about it, like,
Wait a minute. Can I stop? I can do it.
It really changed my thinking of what old is.
You've taught me something today. Clearly, there's no way she's old, you know?
Now I know from today, hey, I don't look at age.
At my age, I feel like I did when I was in my 20s.
There's so many things that I still want to do. There's so many things that I can do. As long as I'm growing and learning, then age doesn't matter.
When people start stopping, that's when they start getting old.
Thank you. Thank you so much.
Thank you.
Okay. Thanks,
Thank
Daphne.
you. It was great meeting you.
How long have you been doing this? Is this a new skill?
40 years.
Wow.
So I hope that video helped you to work to redefine aging for yourself and join in our team, the Bridge team, in working to stop ageism as we learn to understand our internal implicit biases and to move past them so that we can engage in healthcare that understands the whole individual rather than our presuppositions about what an individual should be like based on their age. As with all of my modules and most of my presentations, I like to frame my discussion surrounding a case. So I'd like to talk a little bit about Mr. Smith, a 72-year-old man. He and his wife both recently retired from very busy careers as lawyers. He and his wife had planned to spend their retirement traveling, caring for their grandchildren intermittently, sort of the privilege of grandparents, to have the joy of grandchildren, but also to walk away and enjoy their lives when they can. They volunteer together frequently for City Harvest. They exercise together 4 to 5 days per week. So based on that initial vignette, what do you think? Are the Smiths aging normally? Are they aging healthfully? And more importantly, how do we age? I'd like you to take a few minutes to think about those questions as we pause the module for your thoughts. I'd like to talk a little bit about aging and the concept of immortality as it has captivated our culture across the years. The idea of immortality and enhanced lifespan has captured cultures from the dawn of recorded time. There are legends in Greek mythology and across various cultures, including the myths of Aurora and Tithonus, where Aurora persuaded Zeus to give Tithonus immortality, but forgot to ask for eternal youth. Certainly something that none of us would want. He aged indefinitely, experiencing all the enhanced effects of aging as he reached very high years of age. The myth of the Hyperboreans, long-lived beings that lived beyond the north. Or the myths of the Fountain of Youth, or the Hindu Pool of Youth, the myth of Gilgamesh, or the pursuit of alchemy. The list goes on. The idea of extending our lifespan has captivated humanity for as long as we've been able to capture our thoughts. Reports of exceptionally long-lived humans have captivated humanity across media sources. There have been reports of populations of long-lived humans that have been the focus of research, investigation. All of these pockets of exceptionally long-lived humans have turned out to be perhaps exaggerated and due to limited record-keeping associated with each of those populations. By modern standards, the oldest documented human was a French woman named Jeanne Calment, who died at the age of 122 in 1997. The current oldest living person changes from year to year, depending on who is still with us. As of this writing, the current oldest living person is an individual in Japan, Tomiko Itoka, who is 116 years of age. This changes periodically, and I would encourage you all, if you're curious, to look up at the time of your viewing of this module, who is the current oldest living person at that date and time. A lot of consideration has been given to what is the actual maximum human lifespan. While we are fascinated with the idea of living forever or extending our lifespan indefinitely, there does seem to be an upper limit on how long humans can actually live. On average, the maximum human lifespan seems to be about 115 years of age. This is based on statistical modeling and our current understanding of geroscience. While the absolute upper limit, again based on statistical modeling, appears to be somewhere between the ages of 120 and 150. These are, of course, statistical estimates and are areas of debate and contested research. As I mentioned earlier, the oldest verified person was 122 years of age, and I hope that as we close out this talk, you'll develop a better understanding as how to you, your family, and the patients that you care for can achieve successful aging, and just as importantly, healthful aging. Defining old age is important both statistically in healthcare, health sciences research, but also in our practice of healthcare. Multiple definitions exist, but the most common definition for defining older age, defining the onset of old age, is that given by the U.S. Census Bureau, 65 years and older. Many groups and countries set this as the point in which we become elderly by definition. However, aging is much more rich than this. There are multiple subgroups of aging that should be considered, as each subgroup may have different physiologic characteristics and different healthcare needs. The young old from 65 to 74, the old from 75 to 84, the oldest old 85 plus, centenarians who are 100 plus, and supercentenarians 110 plus. And I would note that centenarians and supercentenarians, as we are aging globally more healthfully, are amongst the fastest growing segments of the population. There are more and more individuals living to 100 and 100 plus years of age. There does seem to be, as we're learning more about physiological aging, periods of paroxysmal aging in which we have accelerated spans of aging. These seem to happen around two different ages, once at around the age of 44 and once around the age of 60, in which we have accelerated periods of biologic aging, and the aging phenotype, how you experience an individual's physical presence of aging, becomes more readily apparent. And biologic aging is also more readily apparent through measures that we'll talk about a little bit later. This is also an area of ongoing research as we work to understand this and perhaps to find pathways to alleviate these periods of paroxysmal aging and extend the period of healthy aging into later life. And if you didn't realize, I hope you will by the end of this talk, we live in an aging world. The world is living longer, and because of that, there are increasing amounts of older adults present both here in the United States and globally. This slide is from data from an article published by the U.S. Census Bureau that discusses population projections spanning from 2020 to 2060. And what you can see from this slide is that as we enter into the latter half of this century, the number of older adults in the United States is expected to dramatically increase from about 15% of the population in 2016 all the way up to 23% of the population in 2060. This has enormous ramifications, not only for you as a healthcare provider, but also for healthcare policy and for insurance expenditures here in the United States, as older adults are far and away the highest utilizers of the healthcare services in the United States. Not only are populations of older adults in the United States expected to expand, as discussed on the previous slide, but just as importantly, we can expect with that expansion of the older population here in the U.S. that diversity in the U.S. is expected to increase as well in the aging population. Racial and ethnic minority populations have already increased from 7.8 million in 2009 to 12.9 million in 2019 and are projected to increase all the way to 27.7 million in 2040. So not only do you have to be prepared as a healthcare provider to treat an increasing population of older adults, you also have to be prepared to treat a population of older adults that has diverse backgrounds. You should be aware as a provider in the United States as well that populations of older adults, of course, are increasing at large, but also are increasing disproportionately in some settings. There are some states that have larger populations of older adults, and healthcare providers practicing in those states should likewise expect that not only do they now have to treat large numbers of older adults, but those populations are likely to expand as time goes on. And there are some states here that you would expect. These are large population centers: California, Florida, Texas, and of course, New York, where I am located right now. Aging in the U.S. Brings all sorts of diversity, diversity of setting, rural versus urban, as an example. But of course, there is large diversity in personal achievement, spanning educational achievement, occupational achievement, and that extends itself into later life, in which there is a large diversity of income achievement. It's important to note that as the population is increasing, of older adults is increasing, there is also increasing number of older adults that are experiencing income insecurity. And disproportionately, the number of older adults that are experiencing income insecurity happen to also fall into certain populations of individuals, including women and minority populations. While I've been talking largely about the United States in regard to the aging of the population here that we are experiencing, it's important to note that this is a global phenomenon. And while some populations, particularly European and Western countries like the United States, have had long periods of time to understand that their population is graying or aging, other countries, particularly Asian countries, have had extraordinarily limited windows to understand that their population is going to age rapidly and adapt to the physical and healthcare needs of that population. There's been diversity in response to this coming challenge. Some countries choosing to prepare very proactively, and others lagging a bit behind in preparing for the growing population of older adults. This slide represents something that I discussed earlier, noting that there are, in particular, growths amongst the oldest old. So 85 plus, 100 plus, those population of older adults globally are increasing at rates that are much higher than the general population of older adults. And this again represents particular populations that should be of interest not only to geriatricians like myself, but to all healthcare providers, as they may have very specific needs that we should be prepared to meet. It's important to note, unfortunately, that not everyone achieves healthful aging. And as we age, there is an overall increase in the prevalence of disability, difficulties with physical functioning as we cross past 65 years of age. This data from the ACL, one of our governmental agencies, indicates that as we cross past 65, individuals with any amount of disability is all the way up to 19%. And you could see across the different areas where disability may be possible, including sensory deficits, deficits in mobility or communication, cognition or self-care. There is remarkable variability. One area of particular concern to us, however, is difficulty with mobility. This is particularly important to geriatricians and all healthcare providers, as it is very difficult for older adults to engage in what matters to them if their mobility is limited. We also live in a culture that is remarkably dependent on cars. Driving from place to place in order to do what matters most to us in our life. And so for folks that have mobility limitations or may have combinations of mobility limitations, sensory deficits, and cognitive deficits, engaging in what matters most to us may be even more difficult, as we may not be able to drive. We can see that this is occurring not only in the United States, but globally. So in high-income countries where we've already had some shifts in our population curve, the burden of chronic or non-communicable diseases, meaning diseases that are associated with the aging process, has increased moving into the 2000s and will continue to increase as we move into the latter half of the 20th or 21st century. Middle and low income countries are going to experience remarkable shifts as increasing amounts of their populations are living into later life and will have higher amounts of chronic non-communicable diseases, medical comorbidities that will require a different healthcare structure, different providers to meet the needs of their population. Back to Mr. Smith. So Mr. Smith, our very healthful lawyer who had reached retirement age, has had some changes. He was dragged in by his wife with a history of gradual onset, very uncharacteristic couch potato behavior. This change was gradually progressive over a 24-month period. Over these 2 years, he had lost his interest in his hobbies. Mr. Smith loved cricket. He loved working on old cars, and he loved gardening. In this time, he'd become forgetful, losing objects in the home, and was starting to have increasing difficulty remembering individuals' names, particularly folks that he did not see as much in the neighborhood or with less frequency than individuals in his family. He now spends most of his days on the couch. He had limited interaction with his wife, which was new, important to note, and had become irritable. He went from a very happy, engaged individual to a grumpy fellow. He was napping intermittently during the day, and because of that, was having subsequent difficulty sleeping at night. He'd become less attentive, and was noted to be mumbling to himself at times. His gait had slowed, but he didn't have any associated tremors or falls at this point. So how on earth did we get here? How did we go from active, volunteering, highly educated individual to an individual that spends most of his days on the couch, not interacting with his wife or engaging in any of the hobbies that he had loved for years?